very much. So we show the first speaker. So unfortunately, he could not come here. So we have the video or presentation. So the first speaker is Muhammad Miftahussurur. Today the tools, he was a PhD student in my university in Japan, and now he is a vice rector of the Airlangga University in Indonesia. So he has also many publications and some award in there. So please show the video sections.
Hello everyone, welcome to my presentations. I'm Professor Muhammad Miftahussurur, MD PhD from Universitas Airlangga Indonesia. Thank you very much for all the committee of ASEAN Stomach and Microbiota Study Group, especially Professor Ratakun Vilaichun for the invitations. In this chance, I would share an interesting topic entitled Gastric Dysbiosis and Helicobacter pylori infection. In the first point, I would give you an overview about human microbiome. All of us understand about microbiota and microbiome. Each human body contains a personalized microbiome that's unique for each individual. The genera or species of microbiome which found in the mouth would be different from the microbiome that is discovered on the esophagus and also gastric as well as intestine indeed. Human microbiome on all parts of the body interconnected in maintaining human health, and many factors such as a diet, host genetics, diseases, drugs, and lifestyle can affect the balance of the microbiota. From the figure, we can get the point that there are three microbial structures in the human body. The healthy microbes consist good microbiota that works to fight off the bad bacteria and restore the balanced body. And the next, commensal microbes, types of microorganisms that reside on either surface of the body or at the mucosa without harming human health. And meanwhile, the bad microbiota, an agent that potentially cause of the disease in the human. On the next slide, I will take up about gastric microbiome as the introductions before we discuss related to gastric dysbiosis, which is defined as any changes to the compositions of commensal communities relative to the community found in healthy individuals. Ladies and gentlemen, there are 5 dominant bacteria and common bacterial genera in healthy stomach. However, some factors such as H. pylori infections, probiotics, change of gut microbiota, drug, diet, age, also geographical conditions, and immunosuppression can cause the imbalance of them. Gastric microecological imbalance are associated with various gastric diseases like gastritis, gastric ulcer, and also gastric carcinoma. In my research with Professor Yoshio Yamaoka in 2020, we conducted LEFSA analysis on Helicobacter pylori negative group, and we discovered significant associations between the presence of gastric microbiome with ethnicity. Streptococcus species and Micrococcus luteus significant presence on Timor ethnicities, Boulardii species and Atopobium species on Javanese ethnic, and Silegella species in Bataknis ethnicities. In addition, ANOVA analysis saw significant difference in the relative abundance Bludella species, Prevotella nansiensis, and also Prevotella intermedia among the ethnic group. Here is the core of my topic today, gastric dysbiosis and H. pylori infection. As I talked before, H. pylori infection is one of the factors that can influence the gastric microbiome balance. The gastric infected of H. pylori might undergoing any chance on gastric environment. There are found 2 conditions of gastric, homeostasis and inflammations. The homeostasis state is maintained by diverse microbes with high microbial richness, whereas on inflammation state occur a dysbiosis that induce the lower microbial richness which favors the growing of unwanted or pathogenic bacteria, then eventually breaks immune homeostasis, leading to chronic inflammations. We have discussed before, infection of H. pylori might be leading the gastric microbiota dysbiosis. The process can be mediated through multiple mechanisms, such as virulence factors, the modification of gastric acidity, host immune response, and also competitions. As a result, there is imbalance in the gastric microbiome, such as increasing proteobacteria and also decreasing Firmicutes genus. Ladies and gentlemen, the figure on the slide represents the difference in the gastric microbiota compositions in H. pylori positive and also H. pylori negative individuals were described. These results suggest that pylori negative individuals bore a microbiota that's more complex and highly diverse compared to H. pylori positive individuals. Other studies also showed that H. pylori colonizations or H. pylori positive status significantly reduce the microbiome diversity that prove with low alpha diversity. This study also found that successful H. pylori eradications increased the gastric microbial diversity, whereas the failed therapy cannot improve the diversity. Ladies and gentlemen, let me show you that H. pylori infection prevalence and gastric dysbiosis in Indonesia. From our research, we discovered that prevalence of H. pylori in Indonesia generally low, that total 10.1% if compared with Japan and Korea, which reached more than 50%. However, in some regions, such as in Timor and Papua Island, the H. pylori prevalence up to 40% and also 42.9% respectively, as well as in the Bali, Sulawesi, and Sumatra Island, that more than 10%. We assumed the low H. pylori infection may be correlated with low gastric cancer incidence in Indonesia, and maybe in some cases where some probability to be infected with non-H. pylori organism. Related to gastric dysbiosis, we observed lower diversity microbiome in H. pylori positive samples compared with H. pylori negative samples. Family Helicobacteriaceae predominated in H. pylori positive samples, whereas families Streptococcus, Prevotolaceae, and also Phalanasolae predominated in the H. pylori negative group. In the species level, H. pylori positive group higher abundance of H. pylori, and also in H. pylori negative group predominated species where Prevotella and Rotia, Phalonella, and Haemophilus parainfluenza become the predominant. We can conclude that H. pylori infection overwhelms other gastric microbiota and dominating the gastric microbial composition. Diversity of gastric microbiome is also analyzed by ethnicity, and we found significant differences in spatial richness, evenness, phylogenetic diversity, and Shannon diversity index among the different ethnic groups. However, when analyzed only in the H. pylori negative group, there were no significant difference in richness, evenness, phylogenetic diversity index, and also Shannon's diversity index among ethnic group. Ladies and gentlemen, when we compare H. pylori and H. pylori negative samples in each ethnic group, we found that there were significantly lower species richness, evenness, Shannon diversity index, and phylogenetic diversity index in the positive group compared to negative groups. Among the ethnicities analysis, the Timorese, Balinese, Papuan ethnic groups had much lower richness, evenness, and phylogenetic diversity index, and of course Shannon diversity index than the Javanese, Dayak Chinese, Bugis, and also Bataknese ethnic groups. Thus, we concluded that H. pylori infections on the gastric microbiome of different ethnic groups was stronger than the influence of an ethnic group designation itself. Other research about H. pylori and gastric microbial alterations will verify that gastric biopsy of H. pylori positive, Quach positive have reduction of bacterial diversity, abundance of Roseburia, and also increase the abundance of Helicobacter pylori and also Haemophilus genera, and overall microbial diversity and richness of biopsies of H. pylori positive and Quach positive was reduced. In the H. pylori samples, we can see the gene functions related to facultative and aerobiosis, mobile element containing and also biofilm forming were depleted, whereas gram-negative species were significantly enriched in H. pylori positive, Quach positive samples. And in addition, the decreases abundance of firmicutes were predicted for the H. pylori positive and Quach positive sample group, contributed to the significant reductions of anaerobic gram-positive potential pathogenic and also oxidative stress tolerant microorganisms. The important point of this research is the presence of Quach gene that was linked to increased gram-negative bacteria, which contributed upregulating lipopolysaccharides, LPS biosynthesis, and weakening the defense of oral microbiota against microorganisms with pathogenic potential. The figure explains how H. pylori can trigger the initiation of gastric cancer, while non-H. pylori microorganisms, especially oral or intestinal opportunistic pathogens, are also involved in gastric cancer development. These microbes and their metabolites promote gastric carcinogenesis by persistent inflammatory response and also immunosuppressive microenvironments. A research study in patients with intestinal metaplasia showed that relative abundance of the T4SS gene contributing bacteria, rhizobials, and also Nesariaceae tend to gradually increases as the abundance of HP decreases. Highly abundant T4SS protein in these patients may promote gastric carcinogenesis. Ladies and gentlemen, a study related gastric dysbiosis and gastric carcinogenesis that published on 2022 on 4 patients group, there was gastritis, gastric adenoma, early gastric cancer group, advanced gastric cancer group, revealed that microbial compositions was significantly different among the 4 groups of each disease status, as well as between the cancer group and non-cancer group. Microbia and also Deferibacterus were significantly more abundant in gastric adenoma than other groups, whereas Acinobacteria were significantly less abundant in advanced gastric cancer than gastric adenoma group. While in the cancer group, the relative abundance of Helicobacter was 10-fold higher than in the non-cancer group. Hence, gastric cancer was characterized with microbial dysbiosis, along with functional changes potentially favoring carcinogenesis. From our research in Indonesia, we discovered some main results. H. pylori and Helicobacter species, OTU, are likely to be factors in gastric mucosal damage. And H. pylori, Helicobacter species, Lactobacillus, Paludibacter, and also the Lister species are likely to be factors in gastric mucosal damage and significantly higher relative abundance in the gastritic group. The lower diversity was observed in the precancerous group with Rotacia dentocariosa. Rotia dentocariosa had significantly higher relative abundance, and among H. pylori negative individuals, Paludibacter species and Dialister species were the species that could influence gastric mucosal damage in Indonesia. After we investigated about gastric microbiota, H. pylori and gastric mucosal damage 2 years later in 2022, we published article Gastric Microbiota, H. pylori infection and GERD. Following the result of study, the diversity score was generally lower in H. pylori positive. Significantly decreases in alpha diversity index was observed in NERD with H. pylori positive, and in the NERD group, H. pylori infections have strong influence and led shift in microbiome compositions, as well as prevents the development of gastric mucosal erosions. Moreover, in ERD group, we found Simpson index of ERD groups was significantly higher than gastritis and NERDs, and of course, similarly in the Shannon index. This figure depicts the analysis result of H. pylori negative group and the alpha diversity measurement by the abundance coverage estimates, and also Fisher test revealed that ERD has significantly lower richness than gastritis and also NERD groups. Ladies and gentlemen, now we enter the next chapter about TPI that can induce gastric dysbiosis. In review studies state that TPI caused significantly lower bacterial counts in fecal samples and lower microbial diversity, as well as an increase in bacteria from the upper gastrointestinal tract, including an increase in Streptococci and also decreases in Prevotellacei. A study about the effects of proton pump inhibitors on gastric mucosa-associated microbiota showed that TPI-treated patients tend to have a higher relative abundance of firmicutes compared with that of untreated patients. Besides that, we also noted that proteobacteria were significantly more abundant and Bacteroidetes less abundant in H. pylori positive patients than H. pylori negative patients. In general level analysis, in the study revealed that Helicobacter were relatively more abundant in H. pylori positive patients. Streptococci in H. pylori positive patients were relatively more abundant in PPI-treated patients than untreated patients. And among untreated H. pylori positive patients display significantly decreased relative abundance of Prevotellacei. Ladies and gentlemen, here the last chapter on my presentation today, that is about H. pylori eradication via gastric microecology modulations. Some options of microbiome modulation strategies such as probiotics, prebiotics, postbiotics, symbiotics, and also FMT or GMT is expected to improve and restore the gastric microflora balance. Reconstruction of the healthy gastric microbiota is a promising strategy for managing microecology dysbiosis associated gastric diseases. In this slide, we can look the result of clinical study that investigated the outcome of concomitant therapy and also standard triple therapy combined probiotics in H. pylori eradications. The results show that in the intention to treat and protocol eradication rate in the STP groups were 83.6% and 87.1%. Whereas in the city group was 86.7% and 91.4%. The two groups showed good compliance and there was no significant difference in any compliance. However, in the city group showed that more serious adverse event than the STP groups. Therefore, adding probiotic to standard triple therapy may be a feasible option to avoid side effect. Other study, a meta-analysis revealed that probiotic supplementation during anti-Helicobacter pylori treatment may be effective for improving H. pylori eradication rates, minimizing the incidence of treatment-related adverse events, and alleviating most disease-related clinical outcomes. Ladies and gentlemen, after probiotic, we move to symbiotic. A meta-analysis study found that symbiotic improved H. pylori eradication rate in comparison with control groups. In addition, the symbiotic supplementations for H. pylori eradication triple treatment, and we showed that the incidence of adverse event was significantly lower. Before we discuss further about fecal microbiota transplant, I want to present a result study that investigated H. pylori infection associates with fecal microbiota. Through this study, we can understand that the impact of H. pylori infection is not restricted to gastrointestinal tract, however, also can affect the fecal microbiota alterations. The highly abundant Prevotella was associated positive with H. pylori infections, whereas the most abundant genus Bacteroides was reduced by 16% in H. pylori case, and the study also identified 4 genera that will all negative associated with H. pylori stool in antigen load. This could be considered to be beneficial, and other may be associated with adverse health effect. Fecal microbiota transplantation or FMT also can be strategy to microbiome modulates. A review study has revealed that FMT can increase the microbial diversity, influence gut bacteria by altering their gene, alter the overall compositions of the microbial metabolites, increase productions of specific microbial metabolites, and also alter the immunological tone of the host and alter the microbiome. which is probably tune X on the gain in the gut-brain axis, potentially leading to the alteration in mood and behavior. There was a study that investigated antitumor effect of fecal microbiota transplantation for microbiome modulations in cancer treatment. There was a study that investigated antitumor effect of fecal microbiota transplantations for microbiome modulations in cancer treatment. And the results reveal FMT is a hopeful method to improve the therapeutic effect of immunotherapy while reducing the side effect of chemotherapy by modulating the gut microbiota. Ladies and gentlemen, before I finalize my presentations, I would like to share the take-home message from my presentations. Number one, there was a core of diverse gastric microbes whose microbial richness contributes to maintain local immune homeostasis. Number second, its pylori infection induced gastric microbiome symbiosis and leading inflammations, as well as some chronic GI tract diseases. Number three, moreover, the to-date research discovered that TPI as the H. pylori eradication therapy leading gastric microbiome alterations. The modulating the microbiota through intervention such as prebiotics, postbiotics, symbiotic, and also fecal microbiota transplants. Gastric microbiota transplant is a promising therapeutic cancer treatment associated complications in the future. Thank you very much for your attention. Good afternoon for all.
Okay, so thank you very much.
Thank you for your excellent presentation, Professor Muhammad. So I guess so we can move on to the second speakers. Professor Yeong Yeh, he is from Malaysia. He will be the next speaker. He's a professor of medicine at the University of Science in Malaysia. He's in immediate past president of the Malaysian Society of Gastroenterology and Hepatology, past scientific chair of Asia Pacific Digestive Disease Week in 2021, a council member of the APAG, and he will present on the topic of impact of Helicobacter pylori loss on gastric cancer and human health. So please, Justin.
And a very good morning to my fellow colleagues and friends. Thank you to, of course, Professor Yoshio, Yamaoka, Professor Varocha, Mahachai. They all are excellent and certainly very experienced investigator in this area. And I'm very happy to also meet some of my good friends here, Professor Somchai, Professor Liu, and Dr. Ratakon for inviting me for the talk. Now, I'm really going to share the experiences from our population. Or have you ever thought about what would be the impact for losing Helicobacter pylori on gastric cancer as well as human health? These are some of the questions. Is it always a good Helicobacter pylori is a dead one? Then the paradox is that what can we learn from a population with a low prevalence? And the last question that I'd like to address through the talk today would be some of the observations after Helicobacter pylori eradication or loss. Now, the first question, whether a good Helicobacter pylori is a dead one. You probably heard about this from Professor David Graham. He is the person who really coined this particular term. A good Helicobacter pylori is a dead one. And this is probably a resounding yes. And there are a few reasons for this. We all know that Helicobacter pylori causes these diseases, including chronic gastritis, and it then leads to atrophic gastritis, leading then to differentiated type of gastric cancer. We call this the chorea cascade. And from the chronic gastritis, it then leads to multiple other diseases, including gastric and duodenal ulcers, mild lymphoma, functional dyspepsia, polyps, idiopathic thrombocytopenic purpura, as well as, of course, the undifferentiated gastric cancer. Also, if you look at the global prevalence of Helicobacter pylori, almost half of our global population harbors this particular infection, with about 4.4 billion estimated to be positive. And in this part of the world, obviously, we see still significantly high burden of Helicobacter pylori infection, but there are certain countries where, for example, Malaysia, where we only have a prevalence of about 28.6%. There are also countries, for example, in India or even Africa, where their Helicobacter pylori infection is high, but their gastric cancer rate is low. So this is what we term as the African and the Indian paradox. Now, gastric cancer still remains a very significant public health hazard. In fact, based on the Global CAN databases in 2018, it's still the 5th most common cancer and the 2nd most common cause of cancer death. We all also know that Helicobacter pylori is a class 1 carcinogen with more than 600 over 1,000 cases of gastric cancer diagnosed just in 2008, with about 5% of cancer cases worldwide, with Japan, China, Korea accounting more than half of the new gastric cancer rate. So obviously, all this data are telling us that we're better off without any Helicobacter pylori. Therefore, let me just tell you this story about a population with a paradoxical low prevalence of Helicobacter pylori. Now, I'm from the northeastern part of Peninsular Malaysia. If you've ever been there, it's a beautiful part of Malaysia. It has nice beach, good food, and wonderful people. However, this particular population, because of its poor economic development, poverty, so they have certain diseases. But interestingly, what we found was in this population, they have low Helicobacter pylori infection. This was first reported in 1994 by my colleague, Dr. Mahendra, where he only found 4.2% of Helicobacter pylori infection among blood donors, 5% among patients with gastric ulcers, and we only have less than 2%, or 2 per 100,000 person years of perforation. This is certainly very low, something which is uncommon observations. If you look at then ethnicity, only 7% compared to 47.4% of non-Malays have this harboring the Helicobacter infection. And obviously, Malays ethnicity somewhat has a lower prevalence. Then my colleague, Dr. Mahendra, he repeated the study again in 1996, and once again, he found a low Helicobacter pylori infection, confirming his previous finding. Interestingly then, what about the other population? We have what we term the aborigines or Orang Asli, and we had this study along with also Professor David Graham, where this is my first time having collaboration with him. And what we found was that in aborigine Orang Asli, where they have poor water and sanitation and hygiene, they actually reported higher prevalence of Helicobacter pylori of 40.6%, but this later then declined to about 10% in the younger cohort. And what happened was that this Orang Asli, they used to live in a jungle, but when they moved closer to the river, their sanitation and their hygiene improved, and therefore we found them to have less Helicobacter pylori infection. Now, not just peptic ulcer disease that's low in this population, We also found that gastric cancer is lowest in the country. No other parts of the country in Malaysia has the lowest incidence and prevalence of gastric cancer. For the period between 1994 to 1999, only 9 cases of gastric cancer were reported. So practically, my surgeons, they have no experience in managing all this perforation or even gastric cancer. They're totally out of job for this particular part of their skills. Now, interestingly, also when we publish about looking at asthma, there's a low prevalence of childhood asthma in this population, with only 5% in 6 to 7 years old and 5.7% in 13 to 14 years old. Now, if you believe in the hygiene hypothesis, where by right, a child who plays a lot in dirty places, they tend to have less hygiene, but they should be protected against asthma. And usually poor hygiene is associated with Helicobacter pylori infection. So in this population, we probably would have, because of the hygiene hypothesis, it somehow contradicts to what we found, because instead of the other way around, we actually found a lower prevalence of childhood asthma. Therefore, we try to look for other paradoxes that is different and really not consistent with what we would expected for someone with a low Helicobacter pylori infection. We also reported this where Helicobacter pylori is inversely correlated with gastroesophageal reflux disease. Now, if you have an inverse relationship, you will probably expect that junctional cancer is higher in this population. But my colleagues and myself, we have reported a lower incidence of reflux esophagitis and even Barrett, only 3.75% of esophagitis and 0.8% of Barrett esophagus, again, very low prevalence. Likewise, when we look at esophageal adenocarcinoma, we only reported an age standardized rate of 1.9 in 100,000 population, including junctional cancers. Therefore, what we can really conclude, say from even the asthma study, Helicobacter pylori itself is probably not the main cause, but really is a surrogate marker. It's just to say the existence of Helicobacter pylori, but it doesn't mean that Helicobacter pylori is responsible for the diseases itself. And even for gastroesophageal reflux disease, the reason why there is an increase in the prevalence is largely because of metabolic reason, where we have shown a clear association with obesity. Our population is not the only one reported this. In fact, the great work by the earlier speaker, Professor Miftahussurur, I think under the tutelage of Professor Yamaoka, also reported similar low prevalence in Indonesian population. Of course, not every Indonesian population, but certainly there is a group of ethnicity within the Indonesian population also reported very similar finding to us. So this is a very interesting story that we would like to tell you. Then the next question you'd like to ask me is, why is this population has a low prevalence? Obviously, it could likely be multifactorial. We did try to explore certain environmental factors. For example, in this particular population, the Malay population, they tend to ingest antimicrobial kind of food, and we term it the budu. Budu is basically a type of fish sauce, which is anti-inflammatory and very high content in probiotics. Again, I think we have heard the previous talks, even in the morning, about the role of probiotics and about what Professor Miftahussurur mentioned about how the diversity is reduced in patients with Helicobacter pylori. In fact, if you look at some of these beneficial microbiota, including lactobacillus and bifidobacterium, they're all both low when you have more Helicobacter. Therefore, probably by ingesting some form of antimicrobial diet, it may potentially cause the low prevalence in this population. There's also potentially lower transmission rate because Helicobacter pylori tend to be associated with poor hygiene. So if you were to improve your hygiene, better refrigeration, and in fact nowadays we are exposed to more antibiotics, all of this would have reduced the transmission rate. In our study as well, we did find there are certain protective gene polymorphisms that give rise to protection for this particular population. We have all heard again the role of gut microbiome. It certainly plays a role. In fact, in our review, we did mention about the role of core infection with the protozoa. While it may worsen the gastric pathology, but if you have a core infection with the helminth, it seems to be more potentially beneficial. It's all about a balance between TH1 and TH2. So in a population where you have more helminths, it's likely to be protective because of this reason against Helicobacter pylori. So what can we summarize so far from this interesting population is that if you have no Helicobacter pylori, you are likely to have very low rates of peptic ulcer disease as well as gastric cancer. Now, it does not protect you from getting asthma, but it does not get you more gastroesophageal reflux disease complications. The reason for the low prevalence are likely multifactorial. It could be environmental, genetic, and of course, there is a role for the gut microbiome. So what are some of the observations after Helicobacter pylori loss or eradication? And what we see is this meta-analysis where if you were to eradicate Helicobacter pylori, it does help to prevent gastric cancers. Shown very clearly here in this meta-analysis, where the first earliest work is by Professor Umura from Japan, where he did a very elegant randomized control trial. But subsequently, you can see that other trials, when we put them together, if you were to eradicate Helicobacter pylori, it certainly favors eradication. Now, if you cannot eradicate, at least successful treatment of the Helicobacter pylori itself also confers protection against gastric cancer. If you were to compare in terms of the relative risk, you can have a protection of up to 54%. We heard a lot this morning with a great lecture from Professor Liu and the rest about how there's an interaction with dysbiosis, antibiotic resistance, and even altered metabolic profile. Now, I would say that these three are like a trilemma. Each of them would really have effect from each other against and towards Helicobacter pylori. So obviously, the relationship between these three conditions, dysbiosis, resistant, altered metabolic profile, can be highly complex and definitely require further studies. Now, the bigger question really is about what would be the impact of loss in Helicobacter pylori against extragastric disorders. And this diagram shows that what are the different types of extragastric disorders that can be associated with Helicobacter pylori. Now, not all of them have a risk. Some of them would have a controversial effect, like what I have shown you about from the earlier section. They may not have asthma. Asthma is definitely controversial. There's also certain conditions that have insignificant effects. The mechanism could be two. One is that the Helicobacter pylori would have induced a chronic low systemic inflammation, or it could be due to a molecular mimicry with a cross-antigen reactions. As I mentioned, some associated are controversial, like asthma and inflammatory bowel disease, but some are also protective. None have proven any causality. So there are studies that indicative that there should be some efficacy after eradication for certain skin condition, as well as even coronary artery disease, but then again, proper RCTs, which is the more robust evidence, are very scarce. So my conclusion are that a good Helicobacter pylori is a dead one. It's very evident from the low prevalent population. The best evidence for eradication so far is prevention of gastric cancer. And other impact on human health is still unclear. And again, we do need studies. And I do hope that all my younger colleagues here would take up on this, come on board, and provide us more clear evidence and association. With that, thank you very much.
Okay, thank you very much. So maybe the question and the answer is after the last section, after the last speakers. So we will go ahead to the last speakers. So he's Dong Quang. He's an associate professor of gastroenterology, senior lecturer, and the vice chair of the Department of Internal Medicine, University of Medicine and Pharmacy in Ho Chi Minh in Vietnam. So his topic is update on management of H. pylori infection. So Dr. please.
Thank you very much, Mr. Chairman. Good afternoon, ladies and gentlemen. First of all, I would like to thank the organizer, especially Professor Varocha and Professor Ratakon, for inviting me to talk on this important symposium. So my talk today will focus on two sections. The first, I would like to talk about the current status of antibiotic resistance and the local resources for H. pylori management in our region. And then I will give a summary on the current guidelines and potential approaches to achieve high eradication rate of H. pylori management. So first of all, I would like to talk about the patterns of H. pylori antibiotic resistance in ASEAN. And this study was written by Professor Ratakon. We show that before 2015, you can see here that some of the countries have already had the clarithromycin resistance rate. Is this the threshold of 15, including you see Cambodia, Vietnam, Indonesia, and Singapore. And here is the pattern of H. pylori antibiotic resistance from 2017 up to now. And in this picture, you see here that there's some data presented in the red color. We show that we have the increasing rate of antibiotic resistance, especially for clarithromycin. You can see here that in Thailand and in Malaysia, now we have the borderline clarithromycin resistance, and it's expected to increasing in the future. And we also have the high clarithromycin rate in Myanmar and extremely high in Vietnam. And for amoxicillin, you can see some increase in Singapore and in Myanmar, and especially very alarming in Vietnam. This study, this data has been shown and confirmed by two separate groups, recently published in international journals. And also we can see some increasing in levofloxacin, extremely high in Vietnam and in Myanmar. So it's not that, it's also very important to talk about the emergence of multi-drug resistant Helicobacter pylori in the region. And over the last 10 years, we have more than 15 studies were included and published in this meta-analysis. We show that in Thailand, we have some data to show that we have this kind of bacteria. Unfortunately, this slide shows that the data was confirmed in the mountain area and in the yellow triangle, but not in the other parts of the country. We have a high prevalence in Cambodia, and recently we have some information from Malaysia, and it's shown that the multi-drug resistant rate increased from 2 to 7% over the last 10 years. And in Singapore, the study from Professor Ang also shown the similar prevalence compared to the Malaysian, about 7%. We have a very high rate in Vietnam, as I showed you, and it has been confirmed in different studies. So it's extremely very important in our daily practice. So how is the interfere, and how about the real world data of management of Helicobacter pylori infection in our region? So I would like to share with you some of the real world data. The first one from Thailand, and in this single center study, we've shown that if we use the triple therapy, so the successful rate is still more than 90%, and the sequential therapy or levofloxacin-based triple therapy also have a good result, but not high as the triple therapy. And in Singapore, there's some study, especially the one from Professor Ang, to show that this is the clinical audit of current H. pylori management in 2018. And this slide shows the temporal change in clarithromycin and amoxicillin resistance rate in Singapore. And you see that the clarithromycin resistance rate steadily increased over time, where we have a more stable amoxicillin resistance rate, about 44% in a recent paper. And the high rate of clarithromycin resistance rate has interfered with the successful rate of eradication, as we show here that you see from before 2000, and the recent data that we have, the eradication rate dropped from more than 90% to less than 70% when we use only 7-day treatment. However, when we use the 14-day treatment, this slide shows that in 2018, we still have a eradication rate of more than 90%. However, with the steadily increasing rate of clarithromycin, we can expect that we still have a high risk of failure with this triple therapy. We have a very difficult situation in Vietnam, and this slide shows the eradication of triple therapy using PPI, amoxicillin, and clarithromycin over the last 10 years. And you see here that over time, we have a very, very low rate of eradication rate of Helicobacter pylori using this triple therapy. And this is the real world audit data. So how about the local resources of BISMUL, PCAP, and antimicrobial susceptibility testing in our region? And recently, the study from 10 Asian countries shown that we have recruited about more than 500 responses from gastroenterologists, as well as other colleagues from other fields like family practice and general practitioner, who also prescribe H. pylori regimens in the daily practice. And in this slide, you can see here that about 2/3 of our colleagues from the government or public hospital, and about 2/3 of them were from the teaching affiliation hospital. So this study showed that for BISMUL, it's unavailable in more than half of the low clarithromycin resistant countries, including Brunei, Laos, Myanmar, and Philippines. And for the other parts of ASEAN, we have a higher resources with more than nearly 80% of the doctors confirm that they can find the drug to use for regimen. Regarding to PCAP, we can see here that it's not available in the majority of countries in our region. And in patients in the interclarithromycin resistant rate, including Malaysia and Singapore and Thailand, we may have a higher resources for using this agent. One important point is about the antimicrobial susceptibility testing, and this slide shows that in nearly half of the situation, our colleague cannot have this test to guide their treatment. And I think that is very important because this slide recruited this response from the teaching hospital and from the government hospital. So if we channelize the data, I think that maybe in the real world, we are lack of this test in more than just 40 to 50% of the cases. I think that this slide is also very important to understand the real world practice of our doctor when we look at the current resources of tests as well as an agent to use for the antibiotic regimen. So for the second part, I would like to talk about the current guidelines and also the potential approaches to achieve high eradication rate. There are some important clinical questions, and the first one is spending time for patient counseling prior to treatment is important, and we have repeated this point very often. And according to the recent WHO Helicobacter pylori management guideline, the good practice point is that we should advise the patient that successful rate depends on their compliance with the treatment, and therefore time should be taken to consult the patient and explain them how to use the drug as well as how they can expect the adverse side effects so that they can overcome when the adverse side effects come. And it's very important to complete the treatment. And it's the ideal that we use written or pictorial information so that it can help the patient to understand more easily and follow our treatment. So this based on based on the key opinion leader, but recently we have meta-analysis from randomized control trial, with very strong evidence to show that. And in this study published early this year in Helicobacter pylori, there were more than nearly 20 RCT with more than 3,000 patients. And this slide shows that patients receive reinforced measurement, including via app or telephone or message, or we can combine that kind of information. So the patient who receive reinforced measurement should have a better medication adherence. They have a higher H. pylori eradication rate, higher symptom relief rate, and a lower incidence of total adverse events with the same regimen. So it's not just the drug, but the information so that the patient follow our instruction and overcome the adverse effect is also very important. So also another important question is that should susceptible testing help to choose the appropriate regimen, because the H. pylori actually is the infection, and treatment for the infection should be ideally based on susceptible testing. And if we use it, when to consider and which one. Now we have a molecular, especially after the COVID-19 pandemic, a disaster, but also it's give the opinion for more hospital to have the machine and the PCR equipment so that we can have the test more popular. So which one, molecular or susceptible testing, should be used? So according to the Maastricht 6, it's reasonable to recommend susceptible testing as a routine test even before we prescribe the first-line treatment. But in the real-life practice, the generalized use of such strategy is still questionable. This slide shows the very interesting point that this meta-analysis shows the current roles of tailored therapy. That means the susceptible testing-based treatment in Helicobacter pylori infection. And there were 34 studies, including more than 9,000 patients. And it shows clearly that when we use the susceptible-based testing, we have a double chance to have the successful rate with the odds ratio of more than 2. But unfortunately, when we look at the eradication rate of tailored therapy, ideally we expect to have 100% of successful. But unfortunately, when you see here that only about less than half of the study confirmed that we have a more than 90% rate of eradication. And if we put the threshold at 95% of eradication rate successful, so we have only 1 of 6 studies to confirm that we have such successful rate. So it informed us that maybe our eradication regimen at the meantime is not optimal, and we should consider for a much better option in the future. So regarding to the time when we should use the susceptible testing, the Maastricht 6 confirmed that recommend that empiric second line and rescue therapy should be guided or based on the local resistance rate if we do not have the machine or the equipment to perform the susceptible testing. And if it's ideal to have the test so that we can choose the good and the appropriate antibiotics to guide our treatment and to have a higher the treatment rate. So one important point is that molecular test guide therapy and susceptible test guided therapy, which one is better? And we have a very interesting study from Professor Liu and his colleague group. And this study also presented this morning by Professor Liu. And when we look at the first line treatment, the eradication rate of the two groups are almost similar. And at the third line treatment is also similar. So this very important study show that the molecular testing guided therapy may play a very important role in the future when we have this testing more popular in our daily practice, because it can save time and it can help us with non-inferior effect compared to the traditional testing. The next question is that how I choose the appropriate regimen. So I think that the most important point is that we have the local data on the antibiotic resistance to help us. But in general, we have the guides that we should base on the penicillin allergic. And if the patient have no penicillin allergic, we can base on the susceptible testing. If it's available, so it should based on the result of the test. And if we do not have the testing, so we should based on the local prevalence of antibiotic resistance, especially clarithromycin. In the low clarithromycin resistant region, we can consider the traditional triple therapy with clarithromycin, amoxicillin, and PPI. And if we fail, then we should consider about bismuth quadro therapy or levofloxacin-based triple or quadro therapy. And in case that we still fail, then again, very important that we should based on the local antibiotic resistance. And in the rescue therapy, the recommendation is that we can use the PPI, rifabutin, and amoxicillin, or high dose PPI plus the amoxicillin. And in case that we have the patient with penicillin allergy, then the quadro therapy, bismuth quadro therapy should be the first choice in this case. This is for the general population, but the recent WHO guideline confirmed that it's very important to consider, and we should be careful for the second line and rescue therapy in high clarithromycin resistant countries. And the quadruple bismuth-based treatment and the levofloxacin-based triple therapy generally show a higher than 80% rate of eradication successful rate. And how we choose is very important that we use the regimen for 14 days, and choose which one should be based on the local availability of the drug as well as the cost of compliance and the allergy history of the patient. But generally, there's some information regarding to the effects of the successful rate of other rescue regimen. The PPI and amoxicillin and rifabutin, even though it's recommended as rescue therapy in Western country, it should be used with very careful, especially in patients in the area with TB prevalence and epidemic. But the concomitant therapy is often ineffective due to the high clarithromycin rate and metronidazole resistance rate, as we shown in the first part of this talk. And for the dual therapy, it may be effective, but there are conflict results across the study in different countries. So I think that we should base on the local study. The Bangkok consensus is now, I think that more than 8 years old. So I think that in the future, we hope to have such information from the regional guideline to help us. In this slide, we also would like to share the opinion from the Vietnam, what we do in Vietnam. So in the patient with H. pylori in high clarithromycin and high metronidazole resistant rate, so the first choice is that we use the bismuth quadro therapy as the first choice, and for alternative, we use the levofloxacin quadro therapy. That means we add bismuth to this regimen. And regarding to the first line, the evidence for bismuth quadro therapy is higher compared to the levofloxacin-based treatment. So the first choice is the bismuth quadro therapy, that we use PPI plus the metronidazole, tetracycline, and bismuth. And if the patient failed to eradicate H. pylori, then we reverse the treatment. So we use the same regimen, but on the opposite arm, if we use the PPI with levofloxacin, amoxicillin, and bismuth as the first choice, then the second choice should be a bismuth quadro therapy with tetracycline and metronidazole, and on the opposite, we use the other regimen. And if we fail after 2 times, then we recommend to use the antibiotic susceptibility testing. And then we select the regimen based on the PPI with 2 sensitive antibiotics with no prior history of allergy. And if we fail, we recommend to the doctor to suspend eradication and consult the patient. And in some high-risk patients, like patient with repeated ulcer bleeding, there may be a necessity of using long-term PPI to maintain the treatment until we have the newer option for treatment. And we do not recommend to use rifabutin, as the TB is very prevalent in Vietnam. And the next one is that how we can optimize the eradication regimen, and I would like to mention about some key factors like the duration, the acid suppression, as well as the bismuth add-on. And regarding to the recommendation of the matrix 6, you see here that the treatment duration should be 14 days for the bismuth quadro therapy, as well as other treatment, unless we have the local evidence, the strong evidence to show that we have a shorter duration therapy, we can confirm at least 80 to 90% successful rate. And one of the most important key factors that determine the effectiveness of the H. pylori treatment regimen is that we should have the good acid secretion inhibition. And in the meantime, we have information to show that, strong evidence to show that not all the PPI are the same. And esomeprazole and rabeprazole versus compared to the previous generation like omeprazole, pantoprazole, or lansoprazole may have some plus benefit. And this analysis shows that rabeprazole and esomeprazole are superior compared to the first generation. And when we use these 2 PPI in the regimen, we have the benefit with the number need to treat about 21 to 23, and there's no significant difference between the 2 agents. For a long time, we talked about the CYP2C19 genotype, but this meta-analysis show that when we use the rabeprazole or the esomeprazole, so the CYP2C19, there's no significant association with the eradication rate. And in a recent network meta-analysis published in Helicobacter pylori this year, this also focused on the different doses of esomeprazole and rabeprazole in the treatment of Helicobacter pylori. And in this slide, you see here this slide, the highest effectiveness we can see with the esomeprazole 40 milligram BID or rabeprazole 40 milligram BID, but consider the adverse effect. There may be a small benefit from esomeprazole 40 milligram BID. So in the matrix 6, there's also a recommendation regarding to the PCAP. And it is to be considered that it's the superior, or at least not inferior to conventional PPI-based tripotherapy for first line and second line treatment. And it's the superior for patients with evidence of antimicrobial resistant infection. And recently we have a more strong data to support this. And this slide shows the information from meta-analysis compared different combination of therapy with the lansoprazole traditional triple therapy. That means lansoprazole and clarithromycin and amoxicillin. So on the top, in the own country, you can see that interestingly the vonoprazan triple therapy or even the vonoprazan duo therapy combining with amoxicillin is much better than compared to the lansoprazole-based triple therapy. And although the drug generated and produced by Asian country, now we also have a strong evidence in the Western country that again the vonoprazole triple therapy or duo therapy is much better than the traditional triple therapy. And more recently, we have meta-analysis consider the efficacy as well as the safety of vonoprazole and amoxicillin duo therapy for Helicobacter pylori eradication. And in this meta-analysis, we have a 5 study with more than 1,500 patients, you see here. And it's shown that the eradication rate of this duo therapy were have more than 80% successful rate even in ITT and per protocol analysis. And this therapy was shown not to be inferior compared to traditional triple therapy. And also very important is that the adverse effect of the duo therapy are lower compared to the those of the triple therapy. So I think that it may be changed in the future, that we the use of the first-line therapy may be changed based on such a landmark study. The role of Bismuth is also very important, and that's the reason why I shared previously about the resources of Bismuth in our Asian country. And it's important because in patients with resistant, antibiotic resistant, especially clarithromycin, amoxicillin and levothyroxine, there may be some benefit when we add Bismuth. It can improve the successful rate of the therapy. And in the recent paper regarding to the use of Bismuth as an add-on for antibiotic-resistant Helicobacter pylori strain, you see here that we have a study enrolled in more than 300 patients. So for the relative risk of pool eradication rate, compare Bismuth containing versus non-Bismuth regimen. So based on this study, we see here that for clarithromycin resistant strain, metronidazole resistant strain or duo strain, we still have a higher relative risk and higher resistant, higher eradication rate when we combine the regimen with Bismuth. But in this slide, we see that for levothyroxine resistant strain, there may be not a significant improvement when we add Bismuth. But in our country, we have some study that we consider that it can be reliable, and it can really help when we add Bismuth on the triple therapy using levothyroxine and amoxicillin. And that's the reason why in Vietnam we recommend to use levothyroxine quadro therapy whenever Bismuth are available. So it's also important in this study to show that when we add on Bismuth, the benefits are only observed in the 14-day treatment and not in the 7-day treatment. And it's also very important when we translate it into the daily practice that we should use the 14-day treatment. So this is some potential therapy target for the non-antibiotic treatment against H. pylori infection, that I think that it may help in the future in the era of multi-drug resistance. So for conclusion, Mr. Chairman, ladies and gentlemen, the first point I would like to address is that the increasing frequency of clarithromycin-resistant strain, especially the emergence of multi-resistant bacteria, is a major challenge in the region. So the molecular testing guide is interesting and it's not inferior to the traditional one, but the general use of this therapy in routine practice is not yet possible. And we should always consult in the patient seriously, it can help to increase the eradication rate and symptom relief. And finally, optimizing ASG secretion inhibition is very important. In PCAP may be a game changer in the future. And by adding bismuth in the regimen of eradication, we may improve the eradication effectiveness. Thank you very much for your attention.
Okay, so thank you very much. So now we have the discussion, but currently the 20 minutes behind the schedule. So if very short questions. So if you have, okay.
Thank you very much, Duc, for your excellent talk. Can I have asked you one question? Because the refractory HP eradication, do you recommend that to use the probiotics in this condition or not? Because the meta-analysis and systematic review also show that about 10 to 20% can increase the eradication rate and also decrease the side effect of the regimen. Thanks.
Thank you, Professor Somchai, for your very important question. So I think that we have evidence to show that we can reduce the side effect and we can have a higher successful rate. And we also discussed this question in when we developed the guideline in Vietnam. But we have less than 80% agreement because one concern is that the regimen for H. pylori eradication have already very complicated. And by using routine anti-probiotic add-on, they may increase the cost of the treatment, and it's not cost effective. And our suggestion in Vietnam is that we can use the probiotic as an add-on very selectively, especially in patients with the history of diarrhea-induced antibiotic-induced diarrhea, or the patient who have the very severe side effect from the previous treatment.
Okay, one more.
Justin, for your questions, I think, thank you so much for excellent talk. You mentioned that the good bug is a dead bug, and you know that in ASEAN, the prevalence of HP is varying between 20 to 70%. For in ASEAN, so we have a paradox of gastric cancers, maybe low in Malaysia, in Thailand, and very high in Singapore. So you think that strategy treatment for HP in ASEAN, we're going to go target to all the HP positive, or we just focus on the symptomatic patients?
Yeah, that's an excellent question. In fact, I will probably say that from the very beginning when we mentioned, a good Helicobacter pylori is a dead one. So probably we should really eradicate whoever been tested positive for it. In fact, we also have our own Malaysian consensus on Helicobacter pylori, published quite recently and just before the passing of Professor K.L. Goh. And we did mention in the consensus, as long as we detected this patient, whether they have uninvestigated dyspepsia or if they were to detect incidentally without any symptoms, they should receive eradication. So that's what our consensus says. Thanks.
So I'd like to close the session, and I thank you for both speakers to discuss with us on the how we have revolutionized the treatment of Helicobacter pylori, and hopefully it can disappear and reduce gastric cancer rate as we have a better eradication regimen for successful eradication. So I thank you both speakers for excellent presentation.